Hello, I'm Andrea Apter. I'm an associate editor of the Journal of Allergy and Clinical Immunology, and I'm here with Dr. Cheryl Hankin and Dr. Linda Cox, who have recently written a very interesting paper on immunotherapy and how it reduces costs in children and adults. Would you like to tell us a little bit about this study?
Well, I'm Linda Cox, and Cheryl Hankin is the lead investigator, but if she will allow me to begin summarizing, and then I'll let you go into greater detail. The Florida Medicaid data is available and in a HIPAA-compliant manner, such that you can get basically all information about health care costs to this Medicaid population, which covers low-income persons. And we have now a 12-year database. And what we looked at in this particular publication is cost of health care in patients who received allergy immunotherapy, newly diagnosed. So they had to have a year look back with no allergic rhinitis diagnosis, and compared them with the matched population, matched for age, and comorbid allergic conditions. And then we followed them and looked at inpatient, outpatient, and pharmacy costs. And I'll let Cheryl summarize the...
So this was a newer study based on two previous studies. One was where we looked at only children in Florida Medicaid. We had fewer years, and we compared pre and post. So pre-allergy immunotherapy to post, and we found significant not only cost savings but significantly less utilization in inpatient, outpatient, and pharmacy. We were intrigued, and it was suggested that a more rigorous way to do this would be to look at the same data set longer and look at children in a matched cohort. So what that means is we took the children who were newly diagnosed with allergic rhinitis, so they didn't have allergic rhinitis in the year before. They also had no immunotherapy whatsoever, no allergy immunotherapy. And we matched them to a group that were newly diagnosed with allergic rhinitis, no immunotherapy, never, and they subsequently never had immunotherapy. And we looked outward for at least 18 months because, of course, sometimes we couldn't catch that very, very long period of time. And we found with children that there were significant savings, not only in terms of cost, but also in healthcare utilization. So they had fewer pharmacy fills, less inpatient use, and less outpatient use that was significant. Then we wondered whether the benefit, which was significant, of health resource use and costs was equally conferred to adults. So we used the same data set, we now expanded it. We did the same sort of study, a little bit different technique for matching and analysis. It was actually extremely rigorous. We matched them again on sex, on age and allergic rhinitis diagnosis. We matched them on race, ethnicity, on comorbid other conditions, so non-allergic related conditions, and on allergy-related conditions. And we did that for adults, so those 18 and over, children, and then combined. And the results were really very startling to me. I didn't expect that we would find that the effect of savings on healthcare utilization as well as costs were significantly better. There was lower utilization, less cost in the 18 months following allergy immunotherapy versus those individuals who didn't have it matched. Of course, the amount of savings was roughly $4,000 over the 18 months, but what we saw was a significant effect within the first 3 months of treatment initiation, which was, again, confirmed from our previous studies with children. So we can say in this real world, because this is what happened, so we're using retrospective claims data. This is not a prospective study. This is what really happened for these people from 1997 to almost present during that time, and just separated them out and examined in real-world context what the benefits of allergy immunotherapy might be.
So that's wonderful. I think it's really interesting, especially the finding that the effect was seen very early. So what does this say for next studies? and for patients.
So let me talk about, so clearly, I'll just set the stage this time, but clearly allergy immunotherapy confers a tremendous or a potentially tremendous benefit. However, only about 3 to 5% of our sample, which is very consistent with other data, only 3 to 5% of what we believe might be clinically appropriate for allergy immunotherapy received treatment, and that's children or adults, and only 16% for children and adults, it was roughly the same, actually completed at least a 3-year course of treatment. About half fell off within the first year. Do you want to talk about the other studies that we've done to show adherence we were just talking about?
You mean what we hope to do, what we plan to do?
Yes.
Well, there's 2 things we're hoping to look at. One is in this existing database, we talked about possibly looking at what goes down in terms of prescription medications, what utilization goes down, because we just looked at the bigger picture, that pharmacy fills went down. We didn't see that intranasal steroids went down or antihistamines because we didn't tease out the specific data, but we have the capability to now look at...
We're actually doing that now.
Yeah, we're doing that. We're looking at what the subset of what the pharmacy fills or outpatient costs went down with allergy immunotherapy. But I think more importantly, the study that Cheryl's alluding to is we want to look at adherence, and this has become big topic in general, but with immunotherapy, it's somewhat notorious for being a treatment that has a very low adherence. And we perceive as physicians that it's due to inconvenience, but we don't really know that that's exactly the reason. And some preliminary work that Cheryl's done or has participated in has suggested there may be other patient reasons for having poor adherence. So the first step of this study will be to do surveys with patients, maybe focus groups, to try to identify the fault areas with adherence, and then and also with physician groups. And then once we identify where the problem lies, and there's probably 3 areas or 4 areas where adherence needs to be tackled, we will then develop or design an intervention step, and we will test that to see if that's effective in improving adherence.
In the Medicaid population?
No, overall. We believe that this is, very consistent. Medicaid may represent a significantly or substantially more ill population, but adherence, we also looked at adherence in a community setting that was non-Medicaid, that was private pay, and we found very similar, very parallel effects where we saw a great drop-off within the first very few referrals, or not referral, but initiation. So there are 2 parts to adherence, and one would be, or more, one would be the actual initiation, and one would be the premature discontinuation. So we really want to look at what prevents, why do we see that 3 to 5% of potentially appropriate patients, and then why do we see this premature, what we're calling premature discontinuation? The implications of this are profound from a public health, which is what excites me from the public health perspective, because if allergy immunotherapy is the only treatment to date that can potentially cure or have a direct effect on allergy, then and can stop the progression or mitigate the progression to asthma and to other sensitivities, development of other sensitivities, then it is in the public health interest to see this. I see it as a preventative health benefit. I'm not sure that payers at this point actually can see that, but my hope is, as a health services researcher, that we can begin to speak that language, to appeal to them and to appeal to the public to see allergy immunotherapy as really a preventative, protective type of treatment.
So do you have any hypotheses from your very preliminary investigations about what might cause people to discontinue medication?
As I'm not a clinician, so I would...
I think we always presume it's inconvenience because of limited survey studies that have cited that as most common, about 40% of reasons to drop out when they were surveyed. But from Cheryl's study with that private practice, I believe, or no, it was from another survey, it was suggested that lack of efficacy.
And patients don't...
From a patient perspective, they didn't feel better. So it might be an expectation issue, that you're starting this treatment and you would expect to see efficacy?
It's very complicated because a lot of immunotherapy is given over seasons, and you might start it out of season, so
Right.
it may or may not feel anything.
Mm-hmm.
It will be very interesting. And another implication is if your idea that people see the effect very early may mean a smaller course.
They may, well, that's
That has
possible.
not been studied, to be honest with you. I don't want to, what is it when you blasphemy, say that nobody's really looked at 1 year versus 2 years.
I know.
And that, in my clinical practice, that's probably probably more a dropout reason than I see for they don't feel it's effective.
Mm-hmm.
Maybe that's because I'm kind of fussy with patient selection, but they feel better.
Mm-hmm.
Well, it bothers,
And then they forget.
it bothers me to think that we
You
would
know what I'm saying?
Yeah.
Because you
You
don't
feel
feel
better
the diabetes, diabetes
or
or
the
you feel
antibiotic you
better,
don't take.
Right.
which is your goal of treatment.
Right.
Well, it would bother me to think that we would go into an intervention when we don't know the basis on which to set that intervention. So I hear a lot of people very eagerly wanting to educate patients, but where is it needed and why would you put your money in one place or another? So let's do this quickly, but let's do it methodically and think through where we're going to get the biggest intervention and the biggest effect for which populations and for which types of diagnoses and comorbidities, etc. So it needs to be more
And will you
specific.
be able to follow patients a long time? Because, as you mentioned, there's some data that immunotherapy may prevent further sensitization, which means you would see the effect in children as they grow up.
We're actually looking at that, and it becomes very complicated. And the reason is that as the children enter into specialty care, they start to receive diagnoses of more severe asthma, etc., because it either hasn't been identified or it hasn't been logged in as a diagnosis. So within the first 3 months, we see this tremendous, and I can't think that it's the immunotherapy is doing this. We see this tremendous burst in new diagnoses of asthma in the children who receive IT.
But not more healthcare costs.
No. Isn't that interesting?
We suspect they had it. That's probably why they got referred to the specialist. And now the specialist is actually going out and giving the appropriate diagnosis. It's very hard to look at this data and figure out who you're going to exclude and include and how to do this and how far back to exclude them. But we think some of these people had new onset rhinitis and went on to have immunotherapy were actually also had asthma that might not have been labeled into their medical.
One idea is to exclude those patients who have asthma within an X period of time from their IT, but I'm not sure what we're missing by doing that.
You might miss some important information. What I was surprised and was wondering about, if you pick up a new diagnosis of asthma when they start immunotherapy, you would expect medication would be given for that, and the healthcare costs would increase, but your healthcare costs decrease.
You're absolutely right.
And that's one of the things that we're hoping to find out when we look at the changes in the medication profile when they go on immunotherapy. What changes are we seeing? That might be answer that question.
That's a good point.
Well, thank you, Dr. Hankin and Dr. Cox. That was a really wonderful discussion and a really interesting paper that I know everyone will want to read.
Thank you very much.
Thank you.